Yes,
Yes,
sir.
sir.
Okay. So delirium is a Latin word derived from the Latin verb called deliro, to be crazy. The literal meaning of this Latin word is patient becomes crazy. And the definition according to the statistical manual of mental disorders, where the first and foremost disturbance that happens is the alteration in the consciousness, and you keep on talking to them, patient will be able to never attend to listen to you and comprehend what you are saying. So lack of attention, alteration in consciousness, cognition, their response to your queries or your actions will not be fully understood, and they don't have proper perception. These four things are considered as the features of delirium: lack of consciousness or disturbance in consciousness, lack of attention, lack of cognition, and perception. And it is a psychiatric syndrome which commonly heralds an increase in morbidity and mortality. So that is the main reason why we should never allow delirium to happen in a patient. And if a patient develops delirium, it has been found that their hospital stay is very much prolonged, and the discharge also takes a long time. So that is another reason why, and it will cost more, so expense will be more and bed occupation will be more. So these are the reasons why delirium should be properly controlled. There are other terminologies used to name delirium. Instead of that, can be called as intensive care psychosis, can be called acute confusional state, acute brain failure, toxic metabolic state, central nervous system toxicity. Sundowning is one of the very colloquial wording that is used. Cerebral insufficiency or organic brain syndrome. All these things also have been called as equivalent to delirium. Now, what are the classical clinical features? Are fluctuating level of consciousness, attention impairment, disorientation, memory impairment, and sleep disturbance, agitation, and emotional liability. All these things are the features of a delirium. And it is a luckily temporary condition, and it is reversible. If you correctly treat the underlying cause, it can get reversed and patient will become coherent, competent, and cognition will come back. And that is the reason why it has to be identified and properly treated. Now, the types of delirium: hyperactive, hypoactive, and mixed type. These are the three types. So, patient can be either very agitated and disoriented, very violent with hallucinations, or it can be very drowsy, confused, apathetic, and not responding, or it can be altered, hyperactive, hypoactive, so which is called the mixed type. So these are the three presentations it can come in. The causes, you can remember the mnemonic delirium itself is a mnemonic for remembering that. So the D stands for drugs like opioids, anticholinergics, sedatives, steroids, uh, chemotherapy agents, and some antibiotics. All these things, when they have been withdrawn, they also cause delirium. Eyes and ears, poor vision and hearing. So patients who use hearing aid or glasses, you should give it back to them as early as possible in the post-op period. Then they will become quiet. And the low flow states like low oxygen, low coronary perfusion with an MI, heart failure, COPD, shock, that can be remembered as low flow states. Infections, commonly UTI and pneumonia. Retention, urinary retention or constipation with a loaded colon, and restraints, which also can worsen the delirium. And intracranial, uh, like CNS metastasis in a patient already having a brain tumor or tumor elsewhere in the secondaries, patient who already has a seizure prior to ICU or the surgery, or any subdural hematoma or CVA or hypertension encephalopathy, which are all occurred during the surgery or in the care. Then U, underhydration, undernutrition, and undersleep. So you remember that, sleeplessness. And M stands for metabolic disorders like hyponatremia, hypoglycemia, or hyperglycemia, thyroid levels alteration, mostly hypothyroidism, hepatic dysfunction, and deficiencies of vitamin B12, folate, etc. And toxic with the increase in lead, manganese, mercury, or alcohol withdrawal. All these things can be causes. So remember to have this mnemonic in mind so that you can mention the causes easily. And this picture gives you the pathophysiology of delirium, how it is happening. So if you see, most of them are transmitter related: cholinergic activation or inhibition, dopamine activation, cytokine excess because of the infection, serotonin activation deficiency, cortisol excess, glutamate activation. So mostly it is related to the neurotransmitters level alteration. And the theories that have been proposed are neuroinflammation. So the postoperative elevation of C-reactive protein and interleukin 6, which are produced in a higher level, they have been identified as cause of delirium. So the peripheral inflammation, these cytokines enter the blood and they go and affect the central nervous system and get translocated there as inflammatory cells and mediators in the CNS. So this accumulation of inflammatory mediators results in loss of synaptic plasticity and neuroapoptosis and neurogenesis. So it affects the central nervous system like this, and that has been claimed as one of the possible theories for delirium. The second is, as I showed in the earlier picture, alterations in the level of the various neurotransmitters, starting from acetylcholine and the dopamine and other things. I have not mentioned all the neurotransmitters here because the picture is already there. And subclinical cerebral vascular events. So cerebral ischemia can be seen in 7 to 10% of old surgical patients, and this is associated with more than double risk of post-op delirium. So any intraoperative prolonged hypotension or post-op hypotension which has caused a reduction in cerebral perfusion pressure for a longer time can result in reversible but prolonged cerebral ischemia, which is the precipitating cause for the delirium. So cerebral perfusion pressures above autoregulatory limit is an independent risk factor for development of post-op delirium. That is why any hypotension intraoperatively should always be corrected as early as possible, especially in the elderly patients, because their cerebral perfusion will get affected. Management algorithm, first you have to preoperative risk assessment and optimization. So you identify who are all the patients who are likely to develop post-op delirium, then to try to correct it, the preoperative risk reduction. For example, nowadays we try to do what is called on-arrival block for all patients with fractured neck of femur. We try to give them a femoral nerve block so that shifting, taking them for X-ray or a waiting period till the surgery gets fixed, they are pain-free. That itself is one of the important reasons for reduction in the post-op delivery. So treatment of pre-op pain, pre-op electrolyte imbalance, pre-op dehydration, all these things are strategies for risk reduction of the delirium risk. And then recognition and management of established delirium, which has happened in the patient, you must treat it as early as possible. And then post-discharge care and specialist follow-up. All these things are done with a multidisciplinary team involvement. So it is not the duty of anesthetic alone. It is teamwork by the intensivist, the surgeon, the psychiatrist, the nursing personnel, the other paramedical people. Everybody should get involved in this, and it's a multidisciplinary teamwork. Now, what are the risk prediction factors? High-risk surgical procedures. They are the mainly causes for post-operative delirium, including abdominal and pelvic surgeries or major emergency surgeries. Neurological, cardiac, or respiratory and other problems which are already existing in the patient is another risk factor. And patient with the functional baseline and sensory deficits, like patients already having hard of hearing or a visual acuity is not good, and where patient acute metabolic derangement and pain are also risk factors which should be attended before you take up the patient. And preoperative interventions are avoid polypharmacy as much as possible. Avoid prolonged fluid fasting. More than 6 hours of NPO is not advocated. Otherwise, you start supplementing with intravenous fluids. Comprehensive geriatric assessment of the elderly should be done. And you have to control preoperative pain. So preoperative pain associated with 1.5 to 3 times higher risk for post-op delirium. That is the reason why we think of giving blocks to relieve the pain in all upper limb and lower limb procedures wherever possible. And the pain imposes a direct cognitive burden, triggers an acute stress response, and increases the risk of other post-operative complications like atelectasis, which may lead to delirium. So in the elderly, not mobilizing and not giving chest therapy leading to atelectasis and pneumonia is one of the important reasons for delirium. Now, the diagnostic criteria, again, there is a disturbance of consciousness, reduced clarity, and reduced ability to focus, sustain, or shift attention. Change in cognition, memory deficit is there. Sometimes, the elderly patient may not be able to identify their own kith and kin. They may ask, who are you? How did I come to the hospital? Or where I am? All these questions are asked by them. And the development of perceptual disturbances according to the pre-existing or establishing the dementia. And disturbances develops over a short period of time, within hours to days. That is another characteristic feature of delirium. It's not a already existing thing. And evidence from history, physical examination, laboratory findings indicate the disturbances are caused by direct physiological causes of general medical conditions. So these are the diagnostic criteria. Coming to the management of delirium, first you must diagnose the delirium correctly through history, physical examination, and then history you have to find out the onset and features, baseline history, whether patient already had dementia or any other neurocognitive disturbances has to be documented, and the risk factors for delirium to be identified, and whether any general medical illnesses or medications, all that history to be taken. Then do a general physical examination like BP, pulse, temperature, routine examination, and whether the patient has any acute trauma and whether he is in pain or not. Then examine all the systems, respiratory system for tachypnea or regular breathing or any lung signs, and examine the CVS, abdomen, CNS for language deficit. Sometimes you may have to do a fundoscopic examination to rule out papillary edema, especially if the patient had an intraoperative persistent hypertension. Then they may develop a brain edema, which may reflect in the form of pulmonary edema. Then look at the ocular movement, examine the motor and sensory system and coordination. Then what are the screening tools for aiding diagnosis of delirium? There is one tool used as what is called Folstein mini mental state examination. You can ask a few questions quickly, and based on that you give the marks, and then you try to evaluate the delirium. And there is a memorial delirium assessment scale, and there is a confusion assessment method, CAM method, which is there. And also, as you said, in the ICU, if you use it, it is called confusion assessment method, ICU. And investigations, what you can do for that are complete blood count. And you can do a CXR, blood and urine culture for any urinary tract infection, and do the electrolytes, especially LFT, possible ammonia increase. And then if there are already existing or exaggerated B12 folate deficiencies, toxicology screening for drug levels or alcohol level, especially in history of alcoholism. pulse oximeter and ABG assessment and CNS imaging is needed to find out any. There can be sudden acute onset focal multiple infarcts, which may be the cause for delirium. So CT scan will be able to tell you that, and then EEG to show what are the various changes that happen. And rarely you may have to do a lumbar puncture to see whether there is any evidence of increased ICP or meningitis. And the three main goals in treatment of delirium are find and reverse the contributory cause to identify the etiology. Second is ensure patient safety while educating the patients and family and staff. Third is the symptomatic treatment of behavioral disturbances associated with delirium. That is, you try to first talk to them, even though they are not able to comprehend, you try to pacify them by repeatedly giving them reassurance and then trying to gently frighten them, not to physically restrain them forcefully or beating them, and try to do all this maneuvers gently. Then intraoperative interventions which can help in reducing delirium, which are been found to be quite effective, are you have to take care of the pain. If the patient is likely to develop delirium after surgery, intraoperative pain relief and post-op pain relief is a very, very important thing for controlling delirium. So use of paracetamol, NSAIDs, which will be routinely due, and they have found that patients undergoing surgery under neuraxial anesthesia develop less delirium than those who develop and undergo surgery under general anesthesia. And nowadays, the use of dexmedetomidine has largely brought down the incidence of post-op or ICU delirium, and the avoidance of intraoperative benzodiazepam and gabapentinoid. These two drugs, even though it is recommended in most of our anesthetic armamentarium as an anxiolytic and additional agent for enhancing analgesia, gabapentinoids. But these two drugs are potential candidates for increasing the post-op delirium. So, especially elderly patients, try to avoid these drugs. And they found no difference by usage of Tiva or volatile anesthetics. So the incidence of delirium has not been shown to be either increased or decreased because of use of Tiva or volatile anesthetic agent. And intraoperative use of ketamine. They thought ketamine itself can cause hallucinations or emergence delirium, but that has not been proved, especially after the use of low doses of ketamine as an analgesic. They found that it has not produced any significant effect on the cost as a cause of delirium postoperatively. And management of delirium is divided into pharmacological and non-pharmacological techniques. So pharmacological techniques are, especially the haloperidol has become the mainstay. The advantage is it can be given by all routes. I think Sivakarna did not mention about the route of administration. He mentioned only 0.5 to 5 milligram as a dosage. But the advantage is it is available as oral tablets. It is available as a parenteral. Serinase is the brand name. So you can give it as an oral tablet. You can give it intramuscularly, or you can give it intravenously, and it is quite effective. If all other causes like underlying infection or electrolyte imbalance or alcohol withdrawal or not giving the patient their hearing aid or their glasses, if you rule out all the other causes and still the patient is delirious, haloperidol is the drug of choice. And dexmedetomidine helps to restore delirium faster, causes less oversedation and less need for non-invasive ventilation in the shorter ICU stay. So after the advent and the use of dexmedetomidine, delirium has come down a lot in the ICU as well as post-op patients. And if patient has been receiving a lot of benzodiazepams inadvertently, then you can reverse the effect with clomazinil or naloxone. And if the patient had any whole energy crisis, you can give a isostigmine to bring back this level. So you must identify whether patient had any excess dose of benzodiazepine, opioids, or muscle relaxants, which may be the cause for delirium. So this is also part of the management of the pharmacological therapy. So coming to non-pharmacological management, with environmental and supportive management, so providing support and orientation, providing unambiguous environment. So remove unnecessary objects, adequate space between beds, avoid using medical jargon in patient's presence, and induce paranoia, and adequate lighting and control excess noise. Then maintaining competence of the patient by encouraging the patient to have self-care, participate in the treatment, and allow uninterrupted sleep. Don't keep on waking up the patient every half an hour to 1 hour saying that you want to check the blood pressure, you want to take a blood sample, you want to feed them. Like that, it should not be done. So uninterrupted sleep is very important. And as early as possible, ambulate the patient. Ambulatory patients should walk 3 times a day, and non-ambulatory patients should undergo full range of movements. If patient is not allowed to get out of the bed, you must do at least movement of all the limbs for 15 minutes thrice a day. And patient and family education, the families have to be educated, because once they come into the ICU and at the time if the patient has a delirium, especially hyperactive delirium, family will get worried. So you have to educate the family also and give them information why it is happening and how it is being tackled. And as the delirium symptoms resolve, the patient and family should be educated about the long-term prognosis in these patients. And the knowledge about delirium risk increased mortality and functional and cognitive decline may be shared with the patient and family as clinically appropriate. And don't hide anything from them. Tell them what is the reason why it is happening and what steps you are taking to treat the patient. Okay? So these are the things that you can mention in your